All right, everybody. A couple of things real quick, then I'm going to start this presentation, which is actually recorded by Dr. Morgan, so it may be a little weird. But we are going to be live again here in just a moment, so hopefully you're still there or have your notifications set to tell you that we're back on. So I've got the Renewal home screen on. I've added CE trauma, as these will be some of your homework assignments tonight, tomorrow, that sort of thing, as we just simply don't have and can't, and almost never have had enough actual live speakers to talk about every single hour. You know, that would be almost 48 different people, and that's just not sure there's 48 people in the area that would come and talk for an hour. So that leaves it to us to fill in those gaps. You know, we have 25 or 26 speakers. There's clearly about 20 some odd hours that are going to have to be done via reading assignments or recorded stuff, or listening to me drone for an hour or something like that. I don't think anybody wants that. So anyway, enough about that. CE Renewal Home, you see now up in there the home screen medical that's been there, and I added CE trauma. There's a few hours there, and we'll have to add a few more. But again, thank you for signing in when you have started the day, and sign out at the end of the day here shortly when we're done. If you're going to go on and do some of the recorded stuff, just don't sign out until you're done with that. Again, just a little brief there. That's kind of the tablet view. And on your phone view, the phone view of your home screen looks a little bit like that. And then there's CE trauma now been added. These reading assignments are actually the first, so don't fall behind these reading assignments. And don't freak out about the 57-page hand hygiene one. The take-home points are just kind of skim through there. You'll figure it out. I bet there's 15 or 20 pages that are like the references, the accolades, the abstract, the authors, that sort of thing. It's not really as long as it looks, but still good information, so don't just blow it off. So, questions on that, throw them in to me directly, or throw them on this next chat window. And it is basically 3 o'clock, just a bit before, and this presentation should be about 30-35 minutes. This is Dr. Morgan, medical director for, I think, all three of the entities involved in this, and most of you listening. He was one of those that simply couldn't be here anytime, but he recorded it one evening at home and brought it to me, so here we still have him involved in it. He just couldn't be here during the daytime because he has a day job now. So, all right, so bear with me here for a moment while I get over to show you his screen. This is Dr. Morgan. You all know who he is, I believe. You don't see him in the ER much anymore, but he's still working at Freeman in the urgent care, so you may see him there. He bounces between Webb City and Joplin, so he's all over. His presentation is on, does it say it on there? It does. It says it on there, ketamine and pain management. So this is going to fall under medical. Let me get rid of that. Medical hours for this 30 minutes or so. And he's going to talk about the ketamine issues that have been seen. We all thought it was a pretty safe one, and it still is, but there's a few concerns we just need to be aware of. So let me get this playing and get the microphone in the right location. He mentioned there's some music at the beginning of it that may go on a little longer than he intended, so hopefully everybody now can see. Whoop, not airway. That was a mistake. Sorry, my bad. It's medical.
This year, period, I hope everyone is doing well. Let's talk about why ketamine is so important. Ketamine can be dangerous if it's not used correctly. I think recently this has come to light in different parts of the country. We'll talk about a couple of those cases briefly when we get to that part. Ketamine is high risk to be used inappropriately by EMS, both in the dosing of it and in some apparent coercion from law enforcement. Unfortunately, that's why it's important that we review the indications and the proper dosing for ketamine. Some recent bad press regarding EMS use of ketamine. That's why it makes it very dangerous for both the patients and the EMS providers, as well as the EMS medical director. And it's important that we review this appropriately. It is a new drug in the drug bag. It's a new toy for us. It's been very popular in its implementation. In fact, over the last 10 to 15 years, it's become an even more popular medication to use in the emergency department for us when we take care of patients. We have slowly transitioned this over to EMS, just like we've done with other drugs and procedures, such as the use of neuromuscular blockers and rapid sequence intubation. Let's talk a little bit about the ketamine pharmacology, what it actually does. Well, it blocks NMDA receptors. These are the excitatory receptors in our body. And it kind of relaxes these receptors, sort of sedates them, which is a big part of why it has such a great effect in taking care of certain types of patients. It dissociates the cortical and the limbic systems. The cortical systems are those higher thinking functions that we have in our cerebrum, and the limbic systems control some of the more basic functions such as breathing and memory functions. It does block some calcium channel blockers, which gives it the effect of causing some vasodilatation and some bronchodilation. These can be very helpful when taking care of certain patients that we don't cause a lot of problems with their breathing apparatus, and so that's why ketamine has one of the great effects of blocking some of these calcium channels to relax some of these more vital functions that we'll have. The sympathomimetic effects, it does help to increase the blood pressure as opposed to a lot of the other drugs that we give that can drop the blood pressure. Makes it a little bit more precarious to administer. Ketamine does not seem to do that. It will increase the blood pressure and also can increase the heart rate. So these are things that have to be monitored very closely to make sure that we are not causing more harm, but in fact are doing what's best for the patient. It does bind to mu receptors. These mu receptors are exactly where drugs like morphine and fentanyl latch onto, and so it's very good as far as being having a symbiotic relationship with the opioids in helping patients with their pain. Well, what is ketamine? It's a dissociative anesthetic. You've all heard this before. It just sort of disconnects the patient from his environment. That's one of the big selling points, so to speak, of using ketamine. For instance, we use it a lot in kids in the emergency department. If we have to sew them or do a very painful procedure, it doesn't necessarily take away all of the pain. It just sort of disconnects them from realizing that the pain is theirs. And it can be very helpful for us in maintaining a calm, relaxed atmosphere as we go about doing these nasty, dirty things that we tend to do to people in the emergency department, and the things you will do on the ambulance. It has an analgesic, an amnestic, and hypnotic effect. As we mentioned before, it disconnects them from the limbic system and the cortical system and helps cause some of these very profound effects that you'll see in your patients. It sedates them. It can relax them so much they may lay there with their eyes closed and not realize you're doing these mean, bad things to them. But it's something that needs to be watched very closely as you're doing that. We use ketamine for a lot of different effects depending on the situation that the patient has found themselves to be in. We use it for behavioral control. We use it for the sedation and relaxation effect. Sometimes it can be a very helpful adjunct in rapid sequence induction and as an intubation agent, and also using it in severe pain, episodes of severe pain, usually as an assistant sort of to the opioids such as morphine and fentanyl. What makes ketamine a good drug? Well, a lot of things. It dissociates the brain from the outside stimuli. It just sort of takes the patient, as I said before, out of their environment and sort of protects their brain so they don't realize these things are going on. It maintains an awake state more so than an unconscious state, but yet a very relaxed state. It helps to maintain their airway. It maintains their blood pressure, which can be very helpful in a lot of the patients that you and I deal with. It does have that analgesic effect, especially when you're using it in conjunction with any of the opioids, and for people who are having difficulty breathing, or also people who react negatively to a lot of the opioids, which can sedate their breathing apparatus and cause them to be in a mild state of respiratory failure. This will help cause some bronchodilation and help move airway or move air through the airways much cleaner. It's also a very good drug, as you know, for the asthmatic patients, just because this effect. When are we going to use this in EMS? Well, we're going to use it for sedation in what we like to term excited delirium. This phrase has recently been challenged as to whether or not it is an actual description of what's going on, but we all know what excited delirium is. It's that crazy patient, the guy coming at you, the guy that has almost superhuman strength. He may or may not be under the influence of drugs. Usually he is, but sometimes it can just strictly be a psychiatric event that he is undergoing that makes him sort of in this manic state that we call excited delirium. I have seen these guys in the ER where you have to have 4 and 5 and 6 people lay on them almost so they don't hurt themselves or hurt anybody else. We also use it for the prolonged extrication. The patient's caught or trapped, and usually they're in moderate to severe pain, and it's going to take a while to get them out of their entrapment, and so it's very good to have an IV placed in these patients and be able to afford them just a little bit of relaxation via ketamine because it does support the blood pressure so nicely. Procedures we may be doing, if you end up doing, say you're providing somebody, you have to do cardioversion, or you have to do a pericardiocentesis or a thoracentesis to alleviate a pneumothorax. A lot of times ketamine can be a godsend in helping to provide these patients a little bit of sedation and disconnection from those procedures. Obviously, we also use it as an adjunct for pain control and also in rapid sequence intubation. It's not usually the only drug that we use for rapid sequence intubation. It should never be your only drug for that, but it can be a helpful co-administered drug to effect that procedure. What's the proper dosage? Well, you can talk to 10 doctors and get 10 different doses for the administration of ketamine, and obviously there are a lot of other things you have to take into effect, such as whether or not a patient has had this before and had a negative effect to it, or whether he may have other comorbid conditions such as COPD, asthma, heart disease, and those kinds of things that may cause them to react a little bit differently. But again, that's why you guys do what you do so well and can always monitor a patient both with the blood pressure and heart rate monitors, as well as the EKG monitors and the end-tidal CO2 detectors. Well, the dosage for the average adult and or pediatric, if you're giving it either as an IV administration or intraosseous, is 1 milligram per kilogram. You need to really keep on top of what the concentration in your vial is for the ketamine, and know exactly how much volume to give for the administration of a certain number of milligrams. But generally we use a milligram per kilogram IV or IO, and the onset is within 60 seconds for most patients. If you're giving it IM, 4 milligrams per kilogram should get you the right dose. That's the neighborhood that I use a lot of times if I cannot get an IV in a patient, or even given this to a pediatric patient for a certain procedure that we may be doing. I use a dose of 4 milligrams per kilogram IM, and the onset is generally between 3 and 5 minutes. Intranasally, you can use a dose of 5 milligrams per kilogram. You give 1/2 of the dose in each nostril via the atomization device that we have stocked on the ambulances. So those are the basic doses. You need to either have a chart or have an idea of how to convert pounds to kilograms, and then also know how much drug you're going to give a patient. And you always want to underdose versus overdose when you're given this medication. Well, let's talk about the adverse effects. Respiratory depression is certainly one of them. I told you before that it does help with bronchodilation and does help maintain a good respiratory drive, as it does dissociate and allow the patient to breathe. But it can have the effect of respiratory depression if it is given in a higher dose than usual. Laryngospasm is something I have observed several times. Usually this only requires assisting the respiration with a bag valve mask, and I have never had to go any further with anybody who developed laryngospasm. They'll just kind of sit and stutter with their breathing almost and act like they're going to stop breathing. But just a few little gentle puffs with a BVM usually will help bring them right out of that, and you won't have to go any further. The emergence reaction is something that we all know about that can happen as the drug is wearing off. You're done with whatever procedure you've had to do on the patient. They're going to be at a higher risk to start getting almost like waking up from a nightmare in some of these patients. That's why it's very, very good practice to make sure that you kind of tone the lights down if at all possible, keep voices and keep the outside stimuli to as much of a minimum as you possibly can, realizing that is hard to do outside the hospital. But if you can do that, that will help patients survive and recover with very minimal emergent reaction as needed. Hypersalivation is something that does also happen with these patients. They'll get what's called a bronchorrhea, which just means they just put out a lot of respiratory secretions. And so just like any other procedure you're going to do on a patient that could affect their respiration, you have to have suction ready. just in case it should become needed. Well, who gets ketamine? Okay, which kind of patients are we going to give that to? Well, the hypotensive patient in respiratory failure, especially if you're getting ready to intubate them, this is a good drug to provide them. The asthmatic patient in respiratory failure, as I just mentioned about the bronchodilation, is very helpful. Patients who are experiencing an excited delirium or are combative, patients that are also needing medical assistance. I'm not talking about the guys generally just fighting the police and being very difficult as far as arresting, with the exception of those that are actually hurting someone or hurting themselves and may not know exactly what they're doing. But these patients can be very helpful, or these patients are excellent for using ketamine on to help. Prolonged extrication due to the trapped limbs or possible fractures and helping them with some of their pain. Cardioversion, as I mentioned, needed in an awake but an unstable patient. And the patients with severe pain that's just not adequately controlled with narcotics. Sometimes you can just take the right amount of veg off of these patients that may be having more pain than you would expect for whatever condition they have. Ketamine can be very helpful with those patients as long as they are monitored. Let's talk about a couple of the bad press cases. One of them happened in Minneapolis where a young black man was dosed with 500 milligrams of ketamine plus Versed. His girlfriend had called EMS, had called 911, and police were sent and EMS was sent. He ended up was fighting with the cops and given this amount of Versed, and I don't recall exactly how much this gentleman weighed, but I did read where this was a higher dose than what should have been given for him. He spent a couple of days in the ICU, and it turned out that he was severely hypoglycemic. That was the reason he was so combative at the time. And of course, in the heat of the battle, I would not fault anyone for wanting to sedate a patient with ketamine in order to get on top of whatever else was going on. But they should have been able to get him sedated enough to where a blood sugar could have been drawn. That should have been in the differential diagnosis. And I think that probably could have been avoided. The other one is a very popular case, a very well-known case out of Aurora, Colorado, where a 23-year-old black man died after being placed in a chokehold, and the police reportedly had been trying to get EMS to dose him with ketamine to get him to quit fighting. He ended up in cardiac arrest, and I believe was subsequently resuscitated at the hospital or en route to the hospital, but then died after that. And of course, you can imagine that the lawsuits are persisting on this. So these are some negative aspects that can happen, and as you can see, both of these have to do with law enforcement. Nothing against law enforcement, but you have to make sure that we do strictly the medical assessments on these patients, and we are not there just to sedate a patient so they can be placed into a chokehold, because when they don't get their oxygen, bad things happen, and that includes patients that are given ketamine. Well, there was a recent position statement put out by the National Association of EMS Physicians, and this was done in conjunction with a couple of other organizations, including the National Association of State EMS Officials, the National EMS Management Association, the National Association of EMTs, and the American Paramedic Association, all recognizing the use of chemical restraint in the agitated and combative patient by EMS providers. I'm not going to read the entire position statement, but it is worthwhile for you to pick that up on the website, the National Association of EMS Physicians website, where you can read that in its entirety. And it's very good as far as giving you guys a backup of knowing that we feel that in a lot of cases this is an appropriate way of managing combative patients, as long as we do it correctly and as long as the patients are monitored. But pick that up and take a peek at that. If you have any questions about it, you can certainly contact me if you have any concerns about their approvals giving for the combative patients. Well, how do you be successful with ketamine? Well, here's how you do it. You pick the right patient. In other words, you got to know the right indications and the right circumstances. You have to make sure that if you're going to give ketamine, that you've considered the other possibilities about what could be wrong with the patient. And I'm speaking primarily about the combative and agitated patients. You need to make sure that you consider those other things, such as the hypoglycemic episode. You got to pick the right dose. You have to know these doses cold, and you have to be able to calculate them, drawing them up, and administering them in the right situation. You have to pick the right kind of monitoring, including EKG monitoring the blood pressure and the heart rate, monitoring the end-tidal CO2, and yes, even monitoring the blood glucose. Knowing how to monitor the patient protects them and protects you, that you have done the best care for your patient. You have to pick the right disposition. You can't dose these patients and then let them go to jail. You can't somewhat sedate a patient with ketamine in order to get handcuffs on them and then let them be taken to jail. Those patients, whether or not they are sedated enough to be unconscious, they need to be transported to the hospital. They need assessment. So you have to pick the right disposition. Ketamine is a great drug. It's a great medication. It has to be used in the right situation at the right time, and then you will get back to all the way. Let's talk about some other drugs that are available for sedating patients and providing pain control. Midazolam, otherwise known as Versed, a good benzodiazepine. Droperidol is a drug that probably is not carried on many ambulances at the present time. Droperidol was very popular back in the 70s and 80s for chemical sedation. We also used it for nausea and vomiting. However, it is one of those drugs that got the dreaded black box warning regarding the QT interval problem, and was taken off a lot of formularies for a long time, and only recently has begun fighting its way back into the hospital and for the use of nausea, vomiting, and for some chemical sedation purposes. Diazepam, everybody knows about using Valium. Benadryl is a good sedative agent that we use a lot in the emergency department as well. And of course, the neuromuscular blockers are drugs that we also use in extreme situations when we must sedate a patient so bad and paralyze them. Of course, that relegates them to the ventilator. Let's talk a little bit about pain management. There has been a push in treating pain a lot more effectively. This is both in the hospital and in the pre-hospital areas. It's been recommended by the Institute of Health that we improve the quality of pre-hospital care, and this was back in 2006. And one one of the ways, or one of the things that they thought needed to be improved was in our management of pain with patients. And so that's why we have gotten much better about allowing and teaching the use of things such as fentanyl and morphine and ketamine for a lot of patients to help control their pain. Pain is becoming more of a vital sign that we are monitoring with patients. And this is something that hospitals take very seriously. That's why they're in the business. They're in the business to control pain. And in fact, that is a big reason that people present to the emergency room and call an ambulance, is because they are in pain. Recommendations were made by a series of panels researching the literature and advising a core working group of physicians and pre-hospital care experts to develop ways to help better treat patients' pain. Recommendations for pain management are to assess the pain as part of your general patient care. Whether you use a certain scale or whether you just ask them, are you having mild or moderate or severe pain? Just assessing that and documenting that. You have to consider all patients with any acute traumatic pain as candidates for pain control, regardless of their transport time. It's important to get on top of pain. You'll have much better patient satisfaction. You get a much better response from their vital signs, and you have a much easier transition over to the ER personnel if you deliver them a patient who you've made a significant difference in their pain. You have to use an age-appropriate pain scale to assess pain. There's several of these out there. I don't know a lot of these. Obviously, everybody knows the scale of 1 to 10 because all of our patients say they're at a 13 on their pain scale. But there are a lot of age-appropriate ones that use the little smiley faces and the frowny faces for the little kids to assess their pain. And whether you use these or not, it can be very helpful in documenting at least whether you are making a difference in a patient's pain. We use a lot of narcotic analgesics for patients in moderate to severe pain, and of course, we're not concerned about creating a whole legion of addicts out there by our use of narcotics. If a patient truly has pain and reports pain, we can make a big difference in this, and that's where the narcotics come into play. We've been using narcotics for literally decades now, and they have always proven a good modality for controlling pain, at least in the hospital and in the pre-hospital areas. You gotta consider the relative contraindications for treating somebody's pain. This includes things such as allergies and also comorbid diseases such as respiratory disease that may cause them to not respond or to over-respond to pain medication administration. You got to reassess them every 5 minutes. You need to reassess them to make sure that their pain is being adequately controlled, and also watch for development of adverse effects. Are they starting to wheeze? Are they having angioedema? Are they becoming more sedated? And you're starting to see, yeah, their pain is controlled, but also look here, their end tidal CO2 is going up. They're starting to retain more carbon dioxide. They're not breathing as much. And so those patients, they need to be assessed frequently, and you need to know, and we need to know about those. Redose the patient. If they're still in significant pain, redose them. That's why we have dosing regimens for these patients as far as knowing how much to administer. And patients metabolize drugs at different rates, and different kinds of pain and different kinds of patient personalities perceive pain in a different way. And so redosing them is a very frequent need for a lot of these patients. You should redose them at half the initial dose. That's just a good rule of thumb for how much more medicine do I give this patient. We'll redose them at half the initial dose, and then keep redoing that. Reassess them every 5 minutes to determine whether or not they're responding, and then treat them again. So the pain control medications that we tend to use the most in EMS is morphine, and the dose for morphine is 0.1 milligrams per kilogram IV. That turns out to be an average of 2 to 5 milligrams every 5 to 10 minutes. And again, don't be afraid to redose these patients. As long as you're monitoring them and assessing their pain, don't be afraid to redose them. Fentanyl has become a lot more popular. It seems to be, it is more potent than morphine. It does not seem to have quite the same duration of effect, at least practically, that I've seen. It seems like you have to dose fentanyl a little bit more frequently, but that's okay as long as you're on top of the patient's pain and reassessing them. There's not going to be any problems with administering this if you know what you're doing. And the dose for this is 1 to 4 micrograms per kilogram IV every 5 to 10 minutes as you need to for those patients. That turns out to be anywhere from 50 micrograms to 100 to 200 micrograms that you're going to be administering most adult patients. Some EMS agencies carry Toradol, ketorolac. We don't carry that right now. Ketorolac is an NSAID, and because of the prevalence of kidney disease and allergies to NSAIDs, we have sort of opted to pass on this medication for now, but I do know of some EMS agencies that do carry this and utilize this to effect. Nitrous oxide was big when I was in EMS, and it was a great pain control drug that was given via inhalation. However, it's not nearly as practical to carry in the ambulance anymore. It requires tanks, and it requires a lot more monitoring and manipulation of tanks and the patient. And so it's more of a practical reason that nitrous oxide has gotten out of EMS. EMS has gotten away from using nitrous oxide for those reasons rather than it not being a great drug, because it really was. And then, of course, we just talked about ketamine, how great an adjunct that can be in helping patients with their pain. When you're given the pain medicine administration, always try to treat their pain if you can. It improves their satisfaction, and it will help improve their hemodynamics. Once their pain is much more tolerable, you don't have to take their pain all the way away, but you can make a significant difference in their hemodynamics just by cutting their pain down with your medications. Monitor them closely. You want to look for adverse effects and whether or not you need to redose these patients. Pain control is something that patients expect and something that patients deserve. And it sort of behooves us to sort of be on top of our game and to treat these patients with what modalities that we have for cutting into their pain and helping them with any of their other problems, such as the excited delirium we talked about, the combative patients, and whether they may need something for pain for prolonged extrication, or strictly as an adjunct, or maybe even an adjunct for rapid sequence intubation as well. If you ever have any questions about the administration of ketamine or other pain medications, please feel free to contact me. I try to keep up on this as much as I can, so you guys can keep doing the job, the fantastic job that you're doing. And I appreciate all your efforts for keeping our patients safe. Thanks very much.
Okay, everybody. I'm gonna mute the mic. I'm gonna leave the live stream running as we will switch away from Dr. Morgan and actually join. I'm gonna butcher her last name, Dr. Pinjali, who is actually going to join us and give a presentation via Zoom or one of the online services. So give me a moment to switch gears, but I'm not going to discontinue the live stream. I'm just going to switch. So hang in there. I'm going to go to the black screen here and turn the mic off. Bye.
So I designed this lecture to be a little bit more interactive, but I don't really see a way that I can look at your comments and stuff. So I think if you guys have questions, I'll just go ahead and answer them at the end, and we'll just kind of work through this lecture. Um, so starting off with the overview, I'm going to be talking about semi-mimic. So the reason I chose some of these pieces, the first pieces actually were things that were called semis brought to our ED, turned out not to be semis. So I just thought it'd be useful to kind of go for those. And then I'm going to go with some genetic arrhythmias that are just a little bit more interesting, in my opinion. Um, so starting off, our first case, we've got a 35-year-old male. He calls 911 for sudden onset chest pain and shortness of breath. Says it started maybe 10 minutes ago. When you get there, he looks really sweaty, he's coughing, he's really short of breath. He can't really tell you much because he's in so much pain. But he does manage to tell you that his pain is worse with movement, worse with deep breaths. He tells you that he has no previous cardiac history. He doesn't think he has any medical history, no family history that he can think of. So you get him in the truck and get EKG, and this is what it looks like. So with all the EKGs that we're going to go over today, we're just going to do it in a systematic way. So we'll always just do rate, rhythm, axis, look at the intervals, look at the QRS morphology, and kind of go from there. So with this one, our rate looks to be around 60. Rhythm looks normal sinus with P's before each QRS. Axis is normal. If we look at our PR intervals, they look to be not long or short, but we do see a few depressed PR intervals. If we look over here in lead 2, you can see a depressed PR interval, and V5, you can see a depressed PR interval. Our QRS morphology looks pretty normal. And then if you look at the ST segments, we see some ST elevations. You can see them in V1, V2, V3, 2. You can pretty much see that. So we have these diffuse ST elevations. We have PR depressions. So this is the part of the lecture where I normally ask you guys what you think this is. But I'm just going to go ahead and tell you. So this is a case of pericarditis. The diffuse ST elevations and the PR depressions are pretty classic for pericarditis. So what is it? Pericarditis is inflammation of the pericardium, specifically the epimyocardium. These guys are going to have pain that's worse with deep breaths, and it's improved with moving forward. If you are able to, you might hear a pericardial friction rub. I personally never heard one, but that's kind of what they teach us, so you can look out for it. And if you hear one, that'd be awesome. Treatment here is going to be NSAIDs. Sometimes you'll get steroids. Sometimes you'll get colchicine, but it's fairly expensive, so it's not given that often. So just some causes of pericarditis to be aware of. Most common is idiopathic. That's all I've seen so far is idiopathic pericarditis. But you can also have infectious causes. The one that we are classically taught is the viral Coxsackie. And then another infectious cause to be aware of is the histoplasma because it's endemic to Missouri here. Other important ones are induced systemic diseases like lupus, radiation-induced, and then the super important one is that post-MI Dressler syndrome, which you might see about a month after someone has an MI. So EKG features of pericarditis, as we discussed with the example EKG that I showed you, we have the diffuse ST elevations. They're going to be most pronounced in the lateral precordial leads. We're also going to see some PR segment depression. And then you can also have ST segment depression in AVR, which wasn't present in the EKG that I showed you, but it's just another thing to look out for. And then one thing that I found that uremic pericarditis involves the epicardium, so you won't see these EKG changes. So another thing that I learned from making this lecture is actually these 4 stages or the 4 changes that you kind of get with pericarditis. So the first stage is kind of what I think we're all fairly familiar with, which is that you get the PR segment depression, especially into AVF, V4, and V6. And then you get the diffuse ST elevation, most notably in 1, V5, V6. And there's really no changes in the T waves here. But then in stage 2, PR segment might depress, or it might be back to isoelectric. The ST segment returns to isoelectric, and your T wave amplitude decreases. In the third stage, PR segment and ST segment are most likely going to be isoelectric, and then you're going to have T wave inversion, most notably in 1, V5, and V6, which you'll notice is where you see the most prominent ST segments in stage 1 as well, which I found interesting just because I didn't know that previously. So it's just another thing to kind of add to that differential when you see T wave inversions on your EKGs. And then stage 4, everything goes back to normal. It's like nothing ever happened. Excuse me. So that's kind of our characteristics in a nutshell. We're going to move on to our next case now. So now we have this 58-year-old male. He was found down by a neighbor who called EMS. They don't really know much about him. They don't know how long he'd been down for, but they found him down and they called. When you get there, he's hypnic, he's tachycardic, hypotensive, and hypoxic. He's really minimally responsive. He's not following commands. He kind of opens his eyes, pulls away from painful stimuli, isn't talking to you at all. So throw him in the truck, get some oxygen on him. Uber is able to tell you that he's got a history of some sort of kidney problems. She thinks he uses drugs. She thinks maybe he gets dialysis. She doesn't know. And that's about all you have. And he can't tell you anything at all. So when you get his EKG, it looks like this. So again, we're just going to do kind of a systematic analysis of the EKG. So looking at this, we have a rate of about 100. Rhythm looks fairly regular. I don't really see any P waves. If they are, they're either buried or they're just not discernible. So we'll call it regular, but we won't call it sinus. And then axis, we have some left axis deviation. Looking at it further, so like I said, no discernible P wave, so we can't say anything about PR intervals. Those QRS complexes are really wide and they look really odd. And then notably, we have these humongous T waves as well. And then if you look at lead 2 here, we have this very characteristic sine wave pattern. So if you put these things together, this bizarre, large QRS complexes, really big T wave, and a sine wave pattern, that'll point you towards hyperkalemia. So I just thought this was an interesting case because this is one that we had, it was called a STEMI, but when he came to us, he was hyperkalemic, and I'm going to kind of walk you through it here. So hyperkalemia, so we have increased potassium that decreases myocardial excitability. So it decreases conduction through the AV and SA nodes both. So hyperkalemia is considered potassium greater than 5.5. Moderate hyperkalemia is going to be greater than 6, and severe hyperkalemia is going to be greater than 7. And interestingly enough, the EKG changes get progressively worse as you get worsening hyperkalemia. So hyperkalemia, I think we all know cardiac arrhythmias is pretty classic. And then we also have some neuromuscular dysfunction that we might see. So we might have muscle weakness, paresthesias, areflexia, ascending paralysis, and GI effects like nausea, vomiting, diarrhea, abdominal pain, etc. So some common causes of hyperkalemia, there's pseudohyperkalemia. So this can be caused by tourniquet use, hemolysis in vitro, so that's more like in the lab, leukocytosis and thrombocytosis. Then we have shift from in the cell to outside of the cell, so that's caused by acidosis, heavy exercise, beta blockers, insulin, digitalis intoxication. And then you have things that increase potassium loads, such as drug, hemolysis, GI bleeding, rhabdomyolysis, cell destruction after chemo, so that would be like that tumor lysis syndrome, and then decreased potassium excretion, things like renal failure, drought, aldosterone deficiency, and then selective defect in excretion. So the reason that I highlighted rhabdo and renal failure here, that's what was going on with our patient in this case. He was in acute on chronic renal failure and he had rhabdo. He was found down. Nobody knows how long he was down for. And his drug abuse may have played a role in that as well. So the changes that we're going to see with hyperkalemia, so with potassium greater than 5, you can expect to see these peaked T waves. So I included this picture here because I personally have been fooled by the normal variant. But when you look at the hyperkalemic T waves, they're more pointy. They kind of go straight up and down, whereas the normal variant has more of a gradual incline and comes back down. So that's what they mean when they talk about these peaked T waves of hyperkalemia. Moderate hyperkalemia, again, that's going to be greater than 6. You'd have wide, flat P waves, prolonged PR interval, and eventually those P waves are going to disappear, which is what we saw on our example EKG. Severe hyperkalemia, again, that's going to be greater than 7. You're going to get this prolonged QRS with bizarre morphology. You're going to get the sine wave pattern that we saw earlier. You're going to get AV block with slow junctional and ventricular escape rhythms, and you're also going to have conduction blocks because, like I said, hyperkalemia will delay conduction through the SA and AV nodes. So, based on this, we can probably say that our patient in this case has severe hyperkalemia because he has pretty much all of these changes. And in fact, his potassium was like 8.7 or something like that. It was crazy high. And then lastly, potassium greater than 9, you'll get, basically they'll die. I mean, you'll get asystole, PEA arrest with a wide, complex, and bizarre rhythm. So how do you treat hyperkalemia? There's 3 mainstays of treatment. Most important thing, and the first thing that you're going to do is membrane stabilization. And then also you can look at intracellular shift and excretion of potassium. So membrane stabilization, like I said, that's going to be our most important thing. And that's going to be done with calcium. So you can use calcium chloride or you can use calcium gluconate. And that's always the first thing that you push. Second thing is the intracellular shift. So if you're concerned about acidosis, sodium bicarb will cause potassium shifting. High dose inhaled albuterol will do it. And then kind of the mainstay treatment for us, the thing that we kind of give everybody that has hyperkalemia is going to be insulin. And that's going to shift the potassium. And then you get the glucose to make sure that their blood sugar doesn't bottom out with the insulin. But even with that, you still have all that potassium still in the body. It's just inside the cells now. So in order to actually get the potassium out of the body, you can give Lasix, you can give K-oxalate, which is the sodium polystyrene sulfonate, or you can do dialysis if it's that severe. So that's kind of our hyperkalemia case in a nutshell there. Our next one is going to be this 25-year-old female. She was found unresponsive by her roommate, LVMS. She's doing CPR when y'all get there. There are the pads on her. Her initial rhythm was AV fib arrest. We get return of spontaneous circulation after shocking her, and her EKG shows this. So again, we'll just kind of go systematically. So our rate is going to be about 100 on the EKG. Rhythm looks to be normal sinus. We have P's before each QRS, and it looks very regular, and our axis is normal. Our PR interval looks normal. QRS morphology, maybe a little bit wide, but not too crazy. And then if you look at your ST segments, you'll notice in V1 and V2, we do see ST segment elevations. But if you look a little closer, you'll see that those ST segments are very downsloping. So we have ST elevation with downsloping ST segments. That is pretty classic for Brugada syndrome. So what is Brugada syndrome? This is a myocardial depolarization disorder. It's caused by mutation in the sodium, calcium, or potassium ion channels. It's more common in male and in East or Southeastern populations, so we don't see it very often here in the States, but it's still something that you can know. That doesn't mean you're not going to see it. Typically, these guys are asymptomatic, and their EKG findings are found incidentally when you're being worked up for something else. However, if they are symptomatic, you can have palpitations, episodes of syncope, seizures from decreased brain perfusion, or they'll end up having ventricular tachydysrhythmias, like our case here, who had prefib arrest. Another important thing to know is that fever can actually provoke these EKG abnormalities. So the EKG abnormalities may not always be there. Some things like fever can like cause it to show up later on. So definitive treatment for these guys is going to be an ICD. If there's some reason that they are unable to have an ICD placed, quinidine can be used in between, before getting the ICD placed if you can't place it right away. So there's type 1 and type 2 Brugadas. So type 1 is what we see in figure A down here, and this is what we saw in our EKG. So this is going to have that coved shape at T segment elevation greater than 2 millimeters, and then it's followed by an inverted T wave. So that's what gives you that downsloping S2 segment. Type 2 is in figure B down there, and that's going to be S2 segment again. Elevation is going to be greater than 2 millimeters. But you're going to have a trough in the S2 segment followed by a positive or biphasic T wave, and it gives you this kind of saddleback pattern, as we can see here. So it's just a quick review of Brugada syndrome. We're going to move on to our next one here. So now we have the 21-year-old male. He has a syncopal episode while walking his dog with his girlfriend. His girlfriend freaks out, calls EMS. He says he's fine. There's nothing wrong with him. He has no complaints. He feels like he doesn't need to be checked up, but his girlfriend is insisting because he had this syncopal episode and she's freaking out. So you get an EKG and it looks like this. So again, our rate is going to be 60 on this guy. Rhythm looks normal sinus. Keys preceding each QRS. And our axis is going to be right axis deviation on this one. Excuse me. So if we look a little bit closer, we do have a fairly short looking QR interval. We have pretty broad QRS complexes, and we have this slurred upstroke going up on these QRS complexes. So at this point, I would ask you if you know what it is, but we'll go a little further here. So we also have these super, super tall R waves. As you can see, they're actually going off the page on this EKG. And we have these inverted T waves in V1 and V3. So this EKG is pretty classic for Wolff-Parkinson-White. And the reason that I wrote that last little box here, that the tall R's and inverted T's mimics right ventricular hypertrophy, is because it is a mimic. It's not a true right ventricular hypertrophy. So if you see that in the context of Wolff-Parkinson-White, don't be fooled into thinking that it's a sign of right ventricular hypertrophy, because it's just a normal variant on the EKG. So Wolff-Parkinson-White, what is it? This is when we have an accessory pathway that circumvents the AV node. This is a genetic condition. The accessory pathway often carries impulse faster than the normal conducting system can. So they can have these tachydysrhythmias where they're going super, super fast, like into the 200s. They might have some other associated cardiac abnormality with hypertrophic cardiomyopathy, atrial septal defect, ventricular septal defects, Epstein's anomaly. All of those are possible. These guys can be asymptomatic, or they might have some recurrent episodes of tachydysrhythmias. Some clinical features of Parkinson-White: palpitations, dizziness, shortness of breath, chest pain, syncope, and all of these symptoms that they might have, they're going to go along with the tachydysrhythmias. So 50% of people diagnosed with Wolff-Parkinson-White will have recorded dysrhythmias. So these dysrhythmias can either be orthodromic or antidromic. And orthodromic is when they have anterograde conduction through the AV node, and then it comes back through the accessory pathway in a retrograde fashion. So that's going to give us a narrow QRS complex. Antidromic is when we have anterograde conduction through the accessory pathways, first through the accessory pathway, and then comes back up through the AV node. And that's going to give us a broad QRS. So just one thing, an easy way to remember it is that orthodromic is going to be narrow QRS, antidromic is going to be the broad QRS. So the classic EKG features of Wolff-Parkinson-White, we're going to see signs of pre-excitation, and that includes a short PR interval less than 0.12, a prolonged QRS greater than 0.12, and the delta wave, which is that slurred upstroke of the QRS. So if you look in this little picture here, if you look over in this picture here, in the box that's labeled pre-excitation, that'll show you kind of as it goes through that accessory pathway, that's what causes that slurring of the upstroke of the QRS. And then an important thing here is that the features that we see on these Wolff-Parkinson-White EKGs, they may not always be present, and they may be enhanced with vagal maneuvers or right after converting them from a tachydysrhythmia. So if you are, converting someone out of a SVT or something like that, it's important to get an EKG following that, because it may reveal to you that, oh, this is because of Parkinson-White. Because after the tachydysrhythmia is gone, it may kind of show the Wolff-Parkinson-White, these classic findings. So that would be a great catch if you found that.
Yes, sir.
The treatment, if they have, excuse me. If they have an unstable tachydysrhythmia, we're going to want to cardiovert them. So signs of instability are going to be hypotension, chest pain, shortness of breath, things like that. And you're just going to go ahead and cardiovert them.
I think it switches off during
break. If they have a stable tachydysrhythmia, you can try vagal maneuvers. So if you look over my little picture here, this is the modified Valsalva. I just did this the other day for a guy in SVT. It's pretty cool. So you just have them blow into a syringe, try and get them to move the plunger until they literally feel like they're going to pass out. And then once they feel like they're going to pass out, lay them down, pick up their legs, wait for about 60 seconds, and their heart rate should come down. If that doesn't work, you can try other things. It's important to note, though, that giving them adenosine can trigger AFib with RVR. And if you have someone in Wolff-Parkinson-White with AFib with RVR, you don't want to give them cardizem. You want to give them procainamide or amiodarone. You want to avoid any kind of AV blockers in these guys if they're going into AFib, because that can trigger a VFib and then they can die. So if you're not having tachydysrhythmias, if they're just there and you see the EKG that I just showed you, you don't need to do any of the stuff that I just talked about. Instead, things are going to be more long-term management. So we're looking at prevention with propranolol or some sort of beta blocker. I think propranolol is the preferred beta blocker. And then definitive treatment is to be ablation of the accessory pathway. So that is Wolff-Parkinson, right? And now for our last case already. So this case of a 15-year-old male. He complains of palpitations while playing basketball. Doesn't really feel too bad. When you get there, he still says having palpitations, but he really doesn't feel bad. He's got no past medical history, but tells me that he has had palpitations before, and he's never seen a doctor for it. So this is his EKG. So you get this EKG and you're like, oh my God. But again, we're just going to go through it systematically. So looking at this, our rate is nearly 200, right? 190. Rhythm is regular, but it's either so fast that we don't see P's or there are no P waves. We've got a left axis deviation here. Our QRS is clearly very wide. And then we have this left bundle branch block pattern with dominant S wave in V1 and broad notched R waves in 1 and AVL. So basically, we have this regular broad complex tachycardia. So knowing that, we will get the differential of kind of two different things here. It can be a VTAC, or this could be SVT with aberrancy, okay? So SVT, supraventricular tachycardia, can refer to any tachycardia that arises above the level of the ventricles. So that includes sinus tach, atrial flutter, ectopic atrial tachycardia, or a junctional reentrant tachycardia. However, we know that there's no P waves here, so that really knocks out sinus tach, atrial flutter, or any atrial tachycardia, and really leaves us with junctional reentrant tachycardia. So we're looking at a VTAC or we're looking at a junctional reentrant tachycardia. So the junctional reentrant tachycardia can be broken into two different categories. It's either an AV nodal reentrant tachycardia or it's an atrioventricular reentrant tachycardia. And if it is, then it's either going to be orthodromic, which is narrow, as I discussed in my previous slides, or it's going to be antidromic, which is wide, which again, I discussed in my previous slides. So we're either looking here at ventricular tachycardia, AV nodal reentrant tachycardia, or an antidromic AV nodal reentrant tachycardia. And that's kind of all we get from the EKG alone. So from here, that's kind of it. You know, we can't really get much more out of it without correlating it clinically what's going on, which is the reason that I wanted to go over this EKG specifically, because I wanted to, again, just that an EKG alone doesn't mean much if you don't have anything to correlate it to clinically. It's one of those things that they really drive home for us, so I wanted to make sure that we talk about it as well. So based on the EKG alone, we can't say anything about this patient. However, I'm going to go ahead and just tell you what it was so that we can discuss it a little further. So this is an example of an antidromic atrioventricular reentrant tachycardia due to Wolff-Parkinson-White. So this is an example of an SVT with aberrancy, kind of going back through the thought process that I walked you through earlier. And I hope I'm not going too fast. But so what is aberrancy? Basically, it's when impulses take an abnormal route and it causes widening of our QRS complex. This is most commonly due to a bundle branch block, or like in this situation, it's due to pre-excitation from something like Wolff-Parkinson-White. So looking at that EKG, it's more likely to be a VTAC if we have absence of typical left bundle branch or right bundle branch morphology, if we have extreme axis deviation, if the QRS is super broad, like greater than 160, if we have AV dissociation, if we have capture beat, which is the first example strip I have up there, that's an example of capture beats, if we have fusion beats, which is the second example I have there for you, those big tombstones. If we have Brugada sign, or if we have the RSR prime with taller left rabbit ear, which is that last little EKG strip I have for you. And the reason that I have that bolded is because that's probably one of the better predictors or better EKG signs that this is likely a VTAC less so than an SVT with aberrancy. However, it's more likely to be an SVT with aberrancy if we have old EKGs to compare it to that show the same bundle branch block pattern, with the same morphology to the wide complex tachycardia, or if there's previous evidence of Wolff-Parkinson-White on previous EKGs. Another reason it's more likely to be an SVT with aberrancy is if the patient has a history of paroxysmal tachycardia that's been terminated with adenosine or vagal maneuvers in the past. So if we think about our patient here, he did say he's had a history of palpitations before, but that's about it. That's all we had really in terms of history. So you get that EKG. How are you going to manage this patient? So first and foremost, every time you have a tachydysrhythmia, are they stable or are they unstable? If they're unstable, it's easy. You shock them. So we're going to do synchronized deep cardioversion. And again, signs of instability are going to be hypotension, chest pain, shortness of breath, things like that. So with the synchronized DC cardioversion, you're going to start with 100 joules monophasic or 70 joules biphasic, and you're going to titrate up as needed. So that's going to be your first shock. If that doesn't work, titrate it up and then keep going. And eventually they will convert. And I chose this picture because this guy looks just way too at peace with the situation. And we all know that's not how it really looks. So, so if they're stable, and you think, you know what, I think this is SVT. I see on this past EKG that they've had Wolff Parkinson White, or they tell me I have Wolff Parkinson White. Then you think, okay, it's probably an SVT. Let's do adenosine, or I guess you can try vagal maneuvers first. If that doesn't work, adenosine. If you think it's more likely to be a VTAC, or if vagal maneuvers and adenosine don't work, then you can do cardioversion, as we just discussed. You can try amiodarone, 150 mg over 10 minutes, or we can do procainamide. Just another thing to keep in mind is that overall, VTAC does account for the majority of wide complex tachycardias. So if you're really in doubt, go ahead and treat it like VTAC. So that's it for my lecture here. My references, I used the link on the Fastlane website, and then I also used our Tintinelli's 9th edition textbook. I know that went a little fast, but if you guys have any questions or any kind of feedback or anything like that from me, I would love to hear it. And if not, then I just want to say thank you for letting me present with you guys. Hopefully next year I'll be able to meet you guys in person. Yeah, so that's it.
I'm not showing any questions.
Sounds great. Dr. Pinjali, can you hear me okay?
Yeah, I can hear you.
Okay, cool. We're going to give it a moment to see if there's any questions that pop across on our chat group in the chat box, but that's fantastic. We appreciate it very much.
Yeah, of course. Thank you.
They're basically all saying, good job, thank you, and get well soon.
Did you hear that at all? It's that one up there, yes, but...
Appreciate you guys making accommodations for me to go ahead and just do this over the internet. It was really nice of you.
Absolutely.
It was really nice of you to put up with us, so thank you.
Yeah.
My pleasure.
All right. I guess we have a whole lot else. We'll sign out with you at least. Anything else come across, Dustin? Okay.
Does her.
Right. I'll leave that up to you, Scotty. Whatever communication you have with her.
I think we're done.
Okay, everybody, that's all we have today for any sort of live presentation or any or presentation over Zoom, WebEx, Google Meet type calls. It's been an interesting time this particular year doing this refresher, but thanks for hanging in there with us, and hopefully this is helping everybody in their busy schedules and then just everything else that's going on, and staying put, and wherever you need to be, wherever you got to be, you're there and you can still participate and get some education out of this. Everybody's in 18 different directions right now at least, so hang in there. We are probably going to sign out for the day. You've got some homework on the webpage, like I was referring to a little over an hour ago. Work on some of that stuff. We have, again, another full day of instructors tomorrow. Well, I guess we're missing one, but we've got some stuff I think we got a plan for that one. So you've got CE Trauma on your webpage, and I don't have anything else for you, so I'm going to go ahead and sign out, and we'll see you tomorrow.